Is it live? Is it showing recording? Is our
Johnstown, New York, it's AAREMS Live.
Well done.
Nice job.
Okay?
Nice job.
All right, thank you.
1 p.m. whichever comes through.
No, I report to the day.
I edited I'm working on that guest on the show when we talked about the banter.
That's all problems.
And on our website, by the way,
I'm here for Edge Square. It's one week a year. I get to go to the shotgun.
I went to Kobe. Is that over there? It's all Kobe because
We just had this morning.
They can change it. They can change it so much time. Each of those shifts.
Well, it depends on how you look at
I used to work for a guy called Everybody Called. It's really good to remember your name.
This is what I've been doing to do.
All right, we'll call the meeting to order. Do the roll call.
Delaware County, Joe Cazzola. Ryan Hale.
Present.
Pat Delameter.
Here.
Maggie Wilson is excused. Fulton County, Margaret Houghton.
Here.
In Country Suite is excused. Jack Farquhar is excused. He's in the dentist's office for surgery today. One of our favorite places to be, isn't it? Michael Tracy.
Here.
Hamlin County, Joyce Belidi is excused. Phil Belidi, present. Davis Warner.
Here.
Gary Wicks is excused. Tom Vascarelli.
Here.
Mickey Schwartz. Here. Trish Green is excused. Tony Agresta.
Here.
Otsego County, Sid Chase.
Here.
Beth McGowan.
Here.
Dr. Markowitz.
Here.
Tim Foster.
Here.
Rich Kirschman.
Here.
Boy, a big gold star for Otsego County today. Garry County, Ed Brandt. Excused. Bill Beavers.
Here.
Ed Hillenbrand is excused. Dr. Luss.
Here.
Ben Lauch.
Here.
Mark Zeek is present.
Present.
Lou Jones is excused. Dr. Leinhardt is excused. So we have a quorum.
All right. Everyone should have received the minutes for the October 19th meeting. Any questions, additions, changes? If not, I'll take a motion to approve.
Is that who? Rich?
Second? Second.
Davis.
Discussion? All in favor?
Aye.
Opposed? Abstaining? Carried. Introduction of guests.
Oh, we have some guests and then some today. Wonderful. We have Mary Ramo and Joe Farrell from the Department of Health and Human Affairs. Okay. We have Peter Brody from the Department of Health. Peter, welcome. We have Kathy Simons from Wells, New York. Kathy, welcome. All right, there you are. Okay. John McMillan from Gavac. We have Howard Huth from SUNY Cobblestill. Nick Brent from Otsego. Welcome, Nick. We have Dave Schaff, who is the Director of Pharmacy at Nathan Latour Hospital. We have Leslie Beadle, who is the Vice President of Administration at Nathan Latour Hospital. Welcome, folks. Very nice to have you. Did I leave anybody out?
Jill.
Jill, did I leave you out? Oh, shame. Jill Dunham from Northampton and Gavac. Very nice to have you all.
Correspondence.
Okay. Everybody got a copy of the correspondence. It was available for people to pick up. And you will note there are some things in there that really are also part of the Secretary's report. Does anybody have any comment about the correspondence? Or?
I know we've got a couple of guests that wanted to speak throughout the meeting, and I really don't have anything to report, so I can pass on mine, so we're into the Secretary's report.
Certainly. On November 7th, Peter Brody of the Department of Health visited our regional office and discussed and demonstrated EPCR QI modalities. We had a very, very productive visit, very interesting visit. Peter is a whiz on dealing with the State Bridge, which is a marvelous repository for uploads, electronic uploads, region-wide and statewide. Very glad to have him with us today. On November 15th, Travis Howe at the Mountain Lakes Regional Office advised of the New York State Senate Bill S2770 that would officially recognize EMS as one of the essential services. I sent a copy of that around to everybody, and for your own information, and possibly to discuss it with people who might be instrumental in its passage. And we have one enforcement action notice received from the Department of Health. A gentleman from Holtzville, New York, which is out on Long Island, had his certification revoked effective the 7th of November, 2017. We are mentioning it here as we are required to do, and full information on this will be in the minutes, which everybody will hopefully receive on Monday or Tuesday of next week. That, sir, is my report.
All right, treasurer's report.
Okay, the financial reports are present here for everybody to get a copy of if they would like. On October 2nd, we sent to Mr. Brandt at DOH a claim for payment in the amount of $1625.45, supporting documentation for the council contract for the period from July 1 through September 30th. On the same date, for the same period, we also sent a claim for payment in the amount of $33,336.17 with supporting documentation for the AAREMS program agency contract. On October 13th, we received a check for $1625.45. Now that was a little unusual since, I believe I reported on this last month, but it bears repeating. We have been approved for the direct deposit system by the Controller's Office, and we have in fact already received payments in previous quarters by direct deposit. On November 14th, we received word from Lee Burns at DOH in response to our inquiries that some confusion in the Controller's Office had been corrected and timely payment of our program agency voucher should be forthcoming. I expect payment by direct deposit by the weekend. And printed report of the cash flow and balance sheet was distributed to all members, or available for distribution to all members. The members of the Executive Committee first received detailed cash flow balance sheets and register reports, the Program Agency Committee, not Executive Committee. They received copies of our canceled checks as per our audit standards arrangements, and they reported.
All is in order.
Okay. Motion.
All right. Any questions for the treasurer? If not, I'll take a motion to accept his report. Beth, second. Tony? Any questions, discussions? All in favor? Opposed, abstaining?
I will abstain as a staff member.
Committee reports, regional program update.
Nothing to report, sir.
Training, nothing.
Nothing to report except that, as mentioned at the REMAC this morning, we have received further input just the last few days on the RSI guidelines and policies and testing. And that has been put together by Joyce and will be sent around to the physicians at the REMAC and to the members of the training committee.
And next month we meet at 10:30 for training here.
10:30 for training next month, that is correct. Really, that's all I have to report on training.
Transportation and standards.
On September 19, 2016, we received an application for transfer of operating authority from the Wells Volunteer Ambulance Corps to the Wells Volunteer Ambulance Corps Incorporated. Since there was a change in wording, there had to be a transfer of authority. And through various ups and downs and corrections of the application, revised paperwork was forwarded to all committee members on October 24th of this year for their review for completeness. And forwarded at the same time was a listing of changes that Dana Jonas of the Department of Health had previously requested of the applicant. And having read through the application very thoroughly, both Tom and myself agree that it is complete. Did not hear from any others on the Transportation and Standards Committee. But at this time, I'd like to make a motion that this council declare that application of TOA complete so that it can be transferred to the Department of Health for fitness and competency ruling, and then we can make a final vote on it at the December meeting.
What
So
service was that?
this was the Wells Volunteer Ambulance Corps in Hamilton County. So I'd like to make that in the form of a motion that it be declared complete.
We have a second.
Second.
Pat?
Sorry.
Avis is barely able to restrain her enthusiasm.
This has been almost a year, and we've seen this application, I think, 4 or 5 times.
Come back from the state.
Come back in regards to it, and even this time, finally, it was almost there, and then we requested a final piece of information that was required regarding the financial status.
And we received that.
And we received that the very next day. We asked for it, and we are there finally. So
I would like to request, as I have urged you to do, to make a large audible vote on this, since it's a statutory vote,
On the completeness.
on the completeness, yes.
Okay, it doesn't have to be a roll call vote, but
No, I'm just,
gotcha.
it's my little pet peeve, sorry.
Okay. Okay, so we've had the motion made and seconded, and we have the discussion on it.
no discussion? All right, all in favor?
Aye.
Opposed? Abstained? All right,
Thank you.
motion carries.
That's good.
There we go.
I know in times, in these times in particular, EMS is struggling. The state is dealing with several consolidations, changes, very similar to this. And I'm sure that this is not going to be the last one that this particular region sees. The one thing that I can't stress enough is, again, this took up a year's time. The committee spent countless hours reviewing it, and I'm sure that you guys spent countless hours every time it got kicked back. It is really in everybody's best interest to consult. I know that we want to do this stuff on our own, and as agencies we don't have a lot of money, but we really should be consulting with attorneys that do this stuff every single day. In the long run, this would have been completed the very first time had an EMS attorney worked on it, and it would have saved a lot of aggravation and hours, man hours for everybody else, including the agencies that work.
So this will be transferred to the Department of Health tomorrow by email, and for a fitness and competency ruling.
State Council report, I don't have anything since the last month. We meet again in January. REMAC. Dr. Fisher.
Can I just outline what the REMAC dealt with this morning? Quickly. Speculator ambulance sought approval to join the BLS CPAP program that was approved. The Town of Boone Fire Department has applied to the Department of Health and to the region to begin basic life support first responder services. That was approved. The ambulance is re-credentialed under the Mountain Lakes REMSCO as per a long-standing agreement with Mountain Lakes that we just provided as an instrumental package. The Antigua Emergency Center is operating at the critical care level of service, and that's presented informationally. Stanford Fire Department is ceasing operations of their ambulance service on April the 1st of next year. Morehouse Volunteer Ambulance is now operating under contract with an adjoining service. And Mr. Farrell provided an update on the status of agency recertifications and inspection requirements in the region, and noted that everyone is up to date in the region. Matter of fact, he awarded us a gold star, which we will gratefully accept. Mary Ramo advised that ALS agencies' controlled substance licensing paperwork is in place, except for one agency which needs to submit a bit more information. And that has been requested from the state. And as noted earlier, there was a short discussion on the RSI 2Y guidelines and testing material. That will be sent out. The latest updates will be sent out to the REMAC and to the committee members. And there was a discussion again on pharmacy services and controlled substance regulations. And that was our REMAC meeting. REMAC next meets in January.
Right. Just trying to speed this along because Nick Multour was very prompt in getting here, and I know there's going to be a little sidebar after this with a couple of people. So County reports, Delaware County.
Nothing to report.
Otsego.
Pretty much business as usual. We have 2 basic classes going on and an AEMT class just announced to start 1st of January.
Schoharie.
We don't have anything, but Howard would like a moment.
I'll be quick. Well, I'll try to be quick. We're gonna run an EMT class that starts in January. We're planning to run an AEMT class that runs May through October. Paramedic enrollment is open for fall of 18, and our winter symposium, again, registration will open on next Wednesday.
What's the cost?
$70, you get hot breakfast, hot lunch, and 8 hours of CME.
Montgomery. All's quiet. Fulton.
Jack's not here, but I haven't heard anything major, so.
Hamilton.
Nothing, well, that would be Ava, you must coordinate for Hamilton.
We're planning on a first responder / EMT course in January. That's about it.
Anybody have any old business? Old business? If not, under new business, we have Peter Brody from Department of Health, who I think would like to say a few words, maybe.
Sure, I don't have a problem with that. Attending the REMAC meeting this morning was interesting. It was nice not having my name mentioned the first 10 minutes 5 times, which was what prompted me to go to Speculator, which was a new adventure all on its own. Rudolph did not guide the way, but passing the state police looking for a dead body on the side of the road certainly instructed the pathway. But one of the topics of discussion that Phil and I had, one of my jobs, mine is a new position, it's funded through a grant from the CDC. I funded through a prescription drug overdose program because the opioid crisis is rampant across the state, and I report on naloxone utilization on a quarterly basis. Those reports are sent to public health directors, county executives, and anybody who wants to receive it to understand how much naloxone is being administered in your county, where substance abuse inpatient stays are being admitted from what county. It's not where they're admitted to, it's where they're admitted from. So if someone in Montgomery County is admitted to Four Winds, in Saratoga, it's credited again, but not credited against, credited to Montgomery County. Also accounts for ER deaths and ER visits and exposures to overdoses, and split into 3 different categories. So the people I work with down in the Public Health Information Group, really take the data that we provide. And part of my job when I was hired was to improve, or is to improve, the quantity and quality of the data. So when we work to facilitate agencies coming on board as using an EPCR system. We now receive the DOH 5136 for any of the agencies. As you update your, do your biannual update paperwork, you'll find yet another form from the state of New York to fill out, and that has to be signed by the program agency as well. And then we will update your contact information for the PCR platform and make sure that we have everything current on that. Working on the quality part of it is where I've been working with Phil and with the other programs, the other 17 program agencies across the state, is providing them with information on where there are gaps in documentation. I commented this morning that I have an agency in New York City, so no, it's not anybody locally for any of the docs listening, who documented that they were giving naloxone sublingually. And I thought, well, I haven't been an ALS provider since 2003. I haven't actively practiced as an ALS provider since 2001, and I just didn't know if naloxone, this was some test program going. So I brought up the New York City protocols and said, nothing here about sublingual, so I called the agency, and the guy's like, seriously? I'm like, well, yeah, and it wasn't like they did it once. It was 500 times in a quarter. 500 doses in a quarter. And the guy's like, okay, now I'm embarrassed because the Department of Health called me directly and told me this. And I said, well, here's my observation. Naloxone is alphabetic. If you look at it alphabetically, the next drug after naloxone is what? Nitroglycerin. All those patients had chest pain or respiratory distress. So I mentioned to the gentleman, I said, you know, you might want to have an in-service or put out an advisory to your staff to look at, you know, how they're documenting chest pains and perhaps implement some QI thought processes to look to see, are we giving naloxone sublingually to treat chest pain? If it's working, congratulations, you found a new modality to improve the patient's situation. If it's not, you might want to look at what you're doing. And he says, that's a good idea. So now he gets a quarterly report from me on how many times they continue to do it. The number has decreased. But what, in all seriousness, what we look at is, what you as agencies can look at is, how can we improve our documentation and how can we utilize the tools at hand? Once an agency goes live on an EPCR platform and they complete the 5136, which, yes, it's not just another form, it actually allows me to turn some things on the state so your data comes through to the bridge so you're compliant with New York State Department of Health Policy 1203. It also allows you to use the QI tools that are in it, use the data and reporting tools that are in it. You know, there was a local agency who just transitioned from a previous client or previous platform to a new platform who, you know, I had to explain that the validation numbers don't come in for the first 24 hours. So we can take a little bit of a deep cleansing breath and wait till tomorrow to look to see what the validation numbers are. But the validation numbers give you an idea of what the initial checks are that are telling you that there might be something wrong. I'll give you an example. You know, when we're looking at the data, when you look at the validation errors, you can see that are your care providers documenting that they asked a female of childbearing years if she's pregnant? You know, that pops up as a validation error. Are there 2 full sets of vital signs? That pops up as a validation error. Is the patient's gender indicated? That pops up as an error. You know, there are a variety of things that are fairly easy to fix that fix that issue. Now, if you want to look at how long is it taking from, we've seen studies before on shoot reports. How long is it taking agency A to make it out the door? And I know this is a bigger issue when you practice out in the rural areas and you respond as part of a volunteer squad. But how long is it taking from the time someone arrives on the scene, figures out that someone's in cardiac arrest, that the monitor is placed, and the first shock is delivered? You know, is that 10 minutes? Is it 3 minutes? You know, where can the agencies improve in ensuring that they're moving efficiently to, you know, what is the expectation or the standard of care? Those are all reports that can easily come out of Image Trend, you know, for you if your EPCR platform doesn't work for you. It doesn't do that work as easily for you. Now, I will tell you, I started on January 23rd. I got my first piece of data to actually come out of there without someone holding my hand through it sometime in early February. So if you're getting frustrated with it, don't be alarmed. It took me full-time 2 weeks to figure it out. But that's something that I can help you with, or we can work with the region, provide you with some support, but you have to be looking for something. You know, we had a conversation with the southwestern region, Johnstown, Olean out there, and they had a doctor who inquired about patients who had one particular medication and how often was it utilized in EMS. And they sent this medication, which of course the Latin version of it, so it had 22 characters, none of which made sense. And I went looking for it in there, and they're on the collaborative protocols. That made the search a little easier. And then I had to go look up, read about it, and said, they don't give this in EMS. You know, and I went back to the agency, I said, that'd be really good if we actually administered it. You know, so look at the drugs that we're administering. I mean, you know, the question came up, I ran a report for Phil, or with Phil, for how many RSIs or MFIs are being done in this region. You know, and I ran the report, and I looked and I said, well, they're all done by one agency for last year. You know, and it was GAVAC. I said, but here's the, you know, here's some non-demographic, non-identifying information on dates and times and when it was done. and what information. But then you could take a bigger or deeper look into it to see exactly where the what vital signs the patient had before and after. If you're looking at naloxone, did it improve the respiratory status of the patient? After you gave the naloxone, how did it improve the situation, or was it appropriate for administration? Moving on from the RSI conversation. So one of the tools that's out there for the agencies to use is along those lines. So if the docs have a piqued curiosity on something that they're looking at, map out what it is exactly it is that you're looking for, and we can work together to draw in a report. I will tell you that for another REMSCO, it took us, they have to file a report for our grant. I learned a lot about how to pull the data out to make it so what we want, so it's easier to track and to follow what actionable items are within the call, and so that you don't get 700 lines of data for one transport that's just from Guy Park Avenue to St. Mary's Hospital. But in that time period, GAVAC or AFD did a large number of interventions. And we have ways to make it so the report works more effectively for you. If there's something you're looking for, let us know. Talk to Phil, and and we can work out the details of a report for you. And it also shows that you're paying attention to your data and you want your data to improve. If your data validity scores are between 80 and 100, you're doing well. If your data scores are in the 20s, you need to look at your ePCR platform and your activities, and we can show you how to get the answers for what you're looking for. The tools are there for you to help you. And one of the comments, I was recently deposed for something from years ago, and that was 3.5 hours of my life I'll never get back after being yelled at by an attorney. But the point is to avoid being in that chair. So if your documentation is comprehensive, it'll help you avoid being in that conversation.
Peter, we have a couple things that come up every time the region tries to run a report, and I know before AFD was a transport agency, we were both turning calls into image trend. So when they would do a search, Phil would do a search to the region, are those numbers skewed because it's the same patient?
No. No. When I run my naloxone report and AFD first response, we'll go back to before July 1st. Because your ambulance didn't start until shortly after July 1st. When I would run it, if AFD gave naloxone and then GAVAC gave it also, on the ride to the hospital, your patient would come up twice, once with each agency. That happens quite heavily in New York City, in Albany, and Schenectady.
Whereas ALSFRs and
Right.
a transport agency. Yeah.
Right. No, but they do come up. It makes it look like it's two patients. You just have to know how to deduplicate the report.
So you do that on your end. So when Phil does a report necessarily, and so
When Phil does a report, he should get both entries, provided if both of you gave the same medication.
Yeah, the way we would document the report is I would put on my report, but prior to this changing, I would do a report. If I gave it, I would have it that it was done by me, but GAVAC would do a PCR saying it was also done by AFD.
Right.
A different PCR system and all that.
Right. The benefit, now you're on the same one.
Correct. But Phil's report would have still made it look like the patient, right?
Made it look like it was the same patient twice. Phil's report would show up that it was the same patient twice.
So the numbers would have, if he just looked at administrations,
Right.
they would have been wrong.
There is a way to mark that someone else is performing the task. However, there's a caution, along with that to make sure that when you're documenting it, that it doesn't come through. To my knowledge, GAVAC does MFIs. I've watched GAVAC do an MFI. And Amsterdam Fire does not, correct?
But we would still document on our PCRs that if the patient was MFI'd by GAVAC.
Right, but the way the data is coming through to the state makes it look like you did the MFI.
Not necessarily, well,
No,
not in
not-
EMS charts.
Not in EMS charts, but that is
It's
what I
7 and 8
said.
differential,
The way it
correct?
comes through to the state is that it makes it look like AFD did
I
the.
guess that's my question. With EMS charts transmits to the state, does page 7 and 8 transmit differently?
I'd have to look specifically. We could find a patient, we could find a patient to do a comparison. Because on the MFI report, it came through that you did one, that AFD did one, not you individually. One of your many minions down there.
Honestly,
Yeah, but the way it comes through, it makes it look like AFD did an MFI. Which raises a question as far as how it's documented. But we, if there's one, then we can arrange a call with Tom and with you, or people you designate, to actually look at that to see how it's actually coming through from a data perspective. So that it doesn't look like you're doing something that you're not. The same thing comes up with some of the BLS agencies as well, who meet up with ALS transporting agencies or ALS intercept agencies. The BLS shouldn't document what the ALS did.
That was also a question, like the BLS fire departments, if they turn in PCR and do PCR. When Phil's getting these information for us, when we ask for information, it doesn't ever seem like the numbers make sense, and I think it's because of the repetition of.
Mm-hmm. Right, and in your previous systems, you both used two different systems until you both went to EMS charts, if I